Our goal is to provide registered nurses 24 hours a day, 7 days a week. Our residents are assessed upon admission for a variety of things, and we address those in our clinical meeting, which is interdisciplinary. A lot of departments are involved in that, such as our therapy department, our quality of life, social services, dietary, so that we can look at the overall resident. We are also looking at the care plans during that time, updating it so that we can have a plan of care developed for the resident. One of the concerns on especially new admissions is the possibility of falls. All falls cannot be anticipated or prevented, and once a fall happens, we do put interventions into place that will hopefully prevent falls or at least decrease the possibility of injury. After each fall, the resident is reassessed, and we start out with the least restrictive intervention possible so that it does not decline their overall function. We start off with maybe possibly putting an alarm on them that will alert staff to unsafe transfers, and then we get progressive from there. It's much like the home environment. Falls do happen, and sometimes they just cannot be prevented. The resident's physician orders the medication, usually the same medications that they've been on at home or at the hospital. Our pharmacy, which is PharMerica, is located in Glasgow, Kentucky. It's in the western part of the state. However, we do have backup pharmacies available that are much closer, just in case we have a late admission or for any other reason that we might need med availability that our pharmacy cannot provide. We have the ability to also do IVs. The resident would not have to go out to the hospital. We could keep them there and save them the transportation, which can sometimes be traumatic within itself. We also have a consulting pharmacist that comes in once a month, goes through every chart on every resident, and also makes recommendations such as medications that would interact with each other that might have an adverse reaction. Restraints is also a topic of interest in most nursing homes. We do try to avoid them. Some things that we have to qualify as a restraint you would not necessarily think of as being a restraint, such as moving the bed against the wall. We will always go with the less restrictive. Some restraints are even considered as an enabler for positioning in a chair or a bed. We will always consult with the physician and, of course, the family as well. Restraints really aren't done at family request. It's an interdisciplinary decision based on the assessment of the resident.